Hi guys, welcome to ENT Uplifter. I am Dr. Mehek, and in this presentation we'll be talking about a very important topic, that is cholesteatoma. So I'll be covering this topic under following headings. First we'll be talking about definition of cholesteatoma, then epidemiology, etiological classification, theories of genesis of cholesteatoma, sites of cholesteatoma, signs, symptoms, examination, investigations and treatment. So coming to the definition, so a simple definition of cholesteatoma. So cholesteatoma is basically epithelial cells. Okay. So in simple words, we can call cholesteatoma as skin within the middle ear cleft. So it is pathological correct on gross microscopic grounds, but the real definition is something else, which was given by Abramson et al. In 1977, and the cholesteatoma term was coined by Jonas Muller in 1838. Now this is not important for you, this is something extra which I am telling you, but yes, the definition of cholesteatoma is important. So we know that it means that the skin within the middle ear cleft, but if you have to write a definition, the real definition of cholesteatoma has 5 points. Okay, so that means that it is a 3D epidermal and connective tissue structure, number one, forming a sac composed of stratified squamous epithelial outer lining and a desquamated keratin center, number two, conforming the middle ear cleft, so it can be either in the middle ear, attic or mastoid, and it has capacity. Now this is about the cholesteatoma, this is about the histological part of cholesteatoma, this is about where it is present. So only when it is present in ear, or there are few other places where cholesteatoma can present in brain, that is not important for you. And so where it is present, and then fourth point is it has capacity of progressive and independent growth involving the underlying bone and replacing the middle ear mucosa. So that is the characteristic of cholesteatoma. So that is the fourth point. And fifth point is tendency to recur. So even when we do cholesteatoma surgeries, it is very important to remove cholesteatoma from everywhere. Even if you leave a bit of cholesteatoma or a particle of cholesteatoma, it will recur. So now the synonyms of cholesteatoma are keratoma, cholestoid, epidermoid cholesteatoma and epidermoidosis. Now moving on to the epidemiology, so incidence is higher in developing countries due to poor socioeconomic standards, poor nutrition, lack of health education and overcrowding in home. Okay, so that's why the incidents are more in developing country, and it affects both sexes and all age groups, but it is slightly more in males and slightly more in adults. Now okay, this is not important. Okay, it is highest among Caucasians, that part you can remember. Now, talking about the etiological classification, now this is something important for you. So we have divided cholesteatoma into two parts, that is congenital and acquired. Now, acquired has primary and secondary. First, if we talk about congenital, that says that it is due to embryonic rest of epithelial tissue. So there is a theory that is embryonic rest of epithelial tissue, that says embryonic rest theory, that says that there are some epithelial tissues which during development are there in the middle ear, and that forms cholesteatoma. But in congenital cholesteatoma, the tympanic membrane is intact, there is no predisposing infection, nothing like that. This is due to some development problem. Okay, so that is what is there in congenital. And in acquired primary, there is no predisposing factor like chronic otitis media. And in acquired secondary, there is active chronic disease with defect in tympanic membrane. So, but it is very difficult to distinguish between acquired primary and acquired secondary on clinical basis. So that's about etiological classification. Now, Talking about the theories of genesis of cholesteatoma, I'm sorry, first so acquired cholesteatoma, in that, like I told you, there is a primary acquired cholesteatoma in which there is no history of previous episode of otitis media or perforation. And there is secondary acquired cholesteatoma in which active middle ear infection, destruction of tympanic membrane and annulus will be present. Now, talking about the theories of genesis of cholesteatoma, we have primary acquired theory and secondary acquired theory. So, in primary acquired theory, we have invagination theory. There won't be any infection, remember that, predisposing infection. So, we have invagination theory, then basal cell hypoplasia theory, and metaplasia theory. In secondary acquired infection, we have epithelial invasion theory, metaplasia theory, and implantation theory. Now, talking about invagination theory or Whitmark's theory, it is also called as Whitmark's theory. In that, there will be obstruction of eustachian tube. So, because of obstruction of eustachian tube, there will be impaired ventilation of middle ear cleft. There will be a negative pressure in the middle ear cleft, and that forms a retraction pocket, and there will be a medial retraction of the tympanic membrane, and that causes narrowing of the passage of middle ear cleft, and that's why there is an impairment in epithelial migration and cleaning. Gradually, because of impaired ventilation, there will be progressive deepening of the pocket, and then it becomes non-self cleaning pocket, and that leads to the accumulation of keratin debris, and that forms cholesteatoma. So that is the invagination theory which was given by Whitmark. Okay. Then we have basal cell hyperplasia theory, which was given by Rudis. So what happens is there is a stimulation of inflammatory injury to pars flaccida. There will be microperforation of basal layer, which is also called as basement membrane, which causes papillary ingrowth and proliferation of epithelial cones and pseudopods through basement membrane. So, there will be inflammation in the basement membrane that forms a microperforation. Because of microperforation, there will be papillary ingrowth of proliferating epithelial cones. The cones will expand and fuse, and that causes cholesteatoma formation. Now we have invasion theory that was given by Habermas. So that says that following perforation by acute otitis media, the squamous epithelium from edges will migrate into middle ear cleft, and that forms cholesteatoma. Now, talking about metaplasia theory, so that was given by Sates. This name is not important, just remember that it was given by Sates. That causes due to chronic middle ear inflammation, there will be epithelial transformation, that is, the columnar endothelium squamous epithelium becomes keratinizing, and that forms cholesteatoma. Now, implantation theory says that due to trauma such as temporal bone fracture or blast injury, the or due to the iatrogenic cause, that is some perforation, residual perforation left after surgery. So, that causes the migration of epithelial cells, or if the epithelial cells are not removed completely during the surgery, so that causes recurrence of cholesteatoma. So in implantation theory, we have two causes. First is due to trauma, and second is due to iatrogenic. That is something which is iatrogenic, means which is done by a surgeon or a doctor. So if the epithelial cells are left, or if the TM is not or if the tympanic membrane is not repaired completely during the surgery. Now, this is the recent theory that is called as mucosal traction theory, that was given by Jackler in 2015, that says that the retraction of drum causes its contact with the ossicle. So the mucosal lining of the tympanic membrane, which is the innermost lining, that attaches to the mucosa of ossicles, and that causes entrapment of the mucosa due to mucosal migration. Now, the trapping of the mucosa and the mucosal element by migration would lead to production of pro-inflammatory cytokines and thereby promoting proliferation and migration of keratinocytes. Now, causes of so that is the mucosal traction theory, and that is the most recent one. Okay. Now, causes of bone destruction in cholesteatoma. Now, cholesteatoma causes bone ossicle destruction. Now, what can be the causes of that? That could be due to pressure theory or pyogenic osteitis. Now, pressure theory is no longer accepted. That says that the pressure necrosis of surrounding bone will cause osteoclastic induced bone resorption. Okay, and pyogenic says that it is due to necrosis or sclerosis. So necrosis or sclerosis will cause bone destruction, and the cytokines that are involved will be like tumor necrosis factors and interleukins and growth factors. Now, what happens is the area which has more reduced blood supply goes into aseptic necrosis first, and that causes the bone destruction. So that area is long process of incus in the ear. Okay, that has very less blood supply, so that's why it goes into necrosis first. Now, the common site of origin of cholesteatoma. Now, first, you just have to remember that the most common site is posterior epitympanum. Okay. Other than that, we have posterior mesotympanum and then anterior epitympanum. But the most common site is posterior epitympanum or posterior etic. There we have to look for cholesteatoma. Okay, and then apart from ear, like I told you, there are other places also, that is petrous, apex, and apart from middle ear, it can even be there in extra auditory canal, and intradurally it can be present in CP angle as well. Now, talking about the pathology, so bony erosion, like I told you before, bony erosion and invasion is the biological hallmark of cholesteatoma. So on magnification, it will appear velvety and bumpy in appearance, and it has cystic keratin mass, this one, and overlying the cystic keratin mass, we have the matrix. Okay, this is the matrix, and this is formed by stratified squamous epithelium, and above this there is a fibrous stroma. So we can tell that cholesteatoma has two parts. One comprises of fibrous stroma and matrix. Matrix is made up of stratified squamous epithelium, and then we have inside we have the keratin mass. This is important. You can even learn this diagram. Now, the symptoms are ear discharge, which will be scanty, purulent, foul smelling, and often continuous. And bloodstain discharge is due to formation of granulation tissue or oral polyp. And hearing loss can be progressive, and most of the time it is conductive hearing loss. Okay, unless there is any other complications which are associated with inner ear. And patient may have very mild conductive hearing loss or normal hearing when the cholesteatoma is bridging the gap of the destroyed ossicle. So when if the ossicles are destroyed and cholesteatoma is bridging that gap, then the hearing loss can be mild, or hearing loss can be or there might not be any hearing loss even though the disease is severe. So that is called as cholesteatoma hearers. Okay, this term is important. It is called as cholesteatoma hearers. Now, signs will be foul smelling or blood-tinged discharge from external auditory canal, attic and marginal perforation, retraction pocket in attic, cholesteatoma flakes can be present, granulation tissues can be present, and oral polyp can be present. Now, if it has gone into complication, suppose patient has gone into temporal bone lobe abscess, then patient will have nominal aphasia. If there is some semicircular canal involvement, then patient will have dizziness and vertigo. If there is facial nerve involvement, then patient might have facial paresis or paralysis. Headache, nausea, and vomiting might be present due to increased intracranial pressure. Diplopia may be present due to Gradinigo syndrome. Drowsiness and bradycardia can be present if it has formed brain abscess, and if there is any painful swelling behind the ear in the mastoid area, then it can be due to mastoid abscess. Now, differential diagnosis of any chronic ear discharge, like we know, it is due to this cholesteatoma, or other than that, it can be due to tuberculous otitis media, or due to middle ear carcinoma, or any granulomatous diseases, or retained foreign body, or chronic or malignant otitis externa. Now, on examination on otomicroscopy or otoendoscopy, um, examination, we will do otomicroscopy and otoendoscopy. Then we have to do tuning fork test, facial nerve test, fistula test. Now, if fistula test is positive, then we should suspect semicircular canal fistula. We have to even test for eustachian tube patency. Apart from that, we should do x-ray and CT scan. Sometimes we do MRI also, but that's not important for you guys. So CT scan is done. CT scan is also not done all the time. Most of the time CT scan is done when there is a revision surgery, or when there is a recurrent case, or when we are dealing with pediatric cholesteatoma, or when cholesteatoma is when we are dealing with cholesteatoma with complications. Okay, but nowadays we prefer doing CT scan. Now, talking about tuning fork test, like I told you, tuning fork test will be suggestive of conductive hearing loss, which may vary. So, if it is moderate, then it will be if it is more than 40 dB, then it may indicate ossicular discontinuity due to erosion of maybe long process of incus or head of stapes. If it is mild, then I told you it is due to cholesteatoma here. It could be, we have to rule out that. Now, on X-ray, we do Schulers view. This is important. So this is the Schulers view. And so what exactly do we see in Schulers view? What exactly do we want to see in Schulers view is that we want to see the dural plate, the sigmoid sinus here, and the pneumatization of the mastoid. This is the external auditory canal. This is the mastoid. This is the your dural plate, and this is the tympanic plate. So like you can see here the mastoid is very pneumatized. It is airy. Okay, you can see lot of honeycomb type of appearance here. But here it's sclerotic. You are just seeing a white opacity here. That means it's sclerotic here, and the mastoid is very small. There is no ventilation here. So what we are seeing is pneumatization pattern, bone destruction, cavity. If there is any cavity in the mastoid, that is, if there is any disease in the mastoid, if there is any low-lying dura or anteriorly placed sigmoid sinus, like here, if the dura is fine. So in your case, you just remember we see dural plate, sigmoid plate, and the pneumatization of mastoid. Okay, and now for otoscopy and microscopy or endoscopy, we see perforation. So most of the time perforation is in the attic area, posterior superior. Now this is the tympanic membrane. This is the anterior quadrant, posterior quadrant, posterior inferior, anterior inferior, posterior inferior. This is posterior superior, this is anterior superior, and this is attic area, and we are seeing perforation in the posterior attic area, which is the most common area. And here you can see some granulation tissues. Okay, and this whitish thing could be cholesteatoma. So we look for perforation, we look for retraction pocket, we see for cholesteatoma. Cholesteatoma will be pearly white flakes of cholesteatoma. We can see the most common site is atic and posterior superior region. In congenital cholesteatoma, we see pearl-like mass that appears behind the intact tympanic membrane. Now, a polyp can be a fleshy red polyp, may be seen filling the meatus, and the ossicular necrosis also we can see. Now, the surgical treatment, so there is no role of medical treatment as such in cholesteatoma, but we can prefer medical treatment in, so it has limited role and it should be considered when the patient is not fit for surgery. If we are dealing with only hearing ear, or where there is a risk of surgery that may not outweigh the benefits, okay. Now the mainstay of treatment is the removal of cholesteatoma and rendering the ears safe. That is our main motive of doing surgery. And the second motive of the surgery is, the secondary motive is to preserve hearing and reconstruction of hearing system. So that's not the first motive. Our first motive, the first motive is to remove the entire disease. Okay. Now the types of surgery that we do is eticotomy, that is transcanal. Then we can go for canal wall up procedure, that is we are preserving the canal, external auditory canal, or we can go for canal wall down procedure. So I won't be mentioning about these procedures in detail here. That will be discussed in a separate presentation. I'm just telling you that what type of surgery can be done. So eticotomy we generally do when there is a limited cholesteatoma in etic area, that and we can clear through eticotomy. And then we have certain indications for canal wall up and canal wall down procedures, which I won't be discussing here. But depending on the question, you have to write. It's not like if they have asked about they can, in long question they can ask you about the definition of the cholesteatoma and treatment. So if treatment has 7 marks, then you don't have to write only this much. You have to discuss these procedures in detail, which I will be discussing in a separate presentation. But if they have asked about cholesteatoma, theories of cholesteatoma, clinical features of cholesteatoma and management, then in management, so you will write about the definition, you will write about the pathogenesis, you will write about the theories, the type of cholesteatomas, then you will write in brief about the clinical features. Then you will, in management, you have to include investigations as well as treatment. Then you can write treatment part in brief. You can write only these 4-5 points along with the name of the surgeries. Okay, so that's about the cholesteatoma. So that's all guys about cholesteatoma. I hope you have understood this topic. If you have any doubts about cholesteatoma, or if you come across any question on cholesteatoma which I have not discussed here, you please let me know. Thanks a lot. Bye bye.